to try and take his seat? And she said, yeah, you could. So the very next day was a Healthcare for All Colorado pancake breakfast in Broomfield, which thankfully wasn't well attended because I spent the whole breakfast talking with Lynn Gillette and Ivan Miller about whether I should try and take Senator Romer's seat. And then I spoke to my husband, who being the good man that he is, of course, said, go for it. And then that following Monday I announced my candidacy. That was November 7th. And December 13th I was selected to take Senator Romer's seat. January 11th began as a senator and introduced a bill for universal health care. So never give up your fight because you never know where it's going to lead you. You know, what I had figured was that even if I didn't win Romer's seat, that I would bring up the fact that I was going to run a universal health care bill as being part of my agenda and hopefully talk the other candidates into being willing to do that. And that did happen. They had all said they would also run a bill for universal health care. So I was going to win one way or the other. Unfortunately, I won the other way. And I had a great education over at least the first month or two about what's different about being a senator than being a doctor. And you know, they're actually about as different on the spectrum of careers as you can be, I think. I said the hardest thing for me is that when you're a doctor, you tell somebody every single thing that you know, because you never know what little thing you're going to tell them that's going to really help them figure out what's going on with your patient. And when you're a senator, you're playing poker. What do I have to tell you? You know? And what are you trying to say to me? And are you telling me the truth? You know? It's a very different game. I've learned how to play it, but now and again I blow it. Like the other day when I told the lobbyists for Douglas County Schools that I'm going to be running an anti-voucher bill this coming year. Maybe that was a little foolish, but I'll get there. I'll get there. It's a little hard not telling the truth all the time. I just need to learn to shut up more. So let me tell you what my idea is, and this is really an evolution of things that have happened. As many of you know, I really didn't know anything about how healthcare was financed and delivered in the United States until 2007 when I was on the Blue Ribbon Commission for Healthcare Reform's Vulnerable Populations Task Force. I worked as a physician for almost 20 years by that time, but always working for Denver Health. All I knew was that every 2 weeks there was a paycheck in my bank account, and that was all I knew. And I didn't have to ask a patient whether they could pay or not. We had a pharmacy, their needs were pretty much met. Medicare did change that some, where I started having to know about people's insurance plans in order to prescribe, but at Denver Health it still wasn't that bad. So I go to the 208 Commission and I hear about all these plans, and I hear that there's a way for Colorado to cover everybody and save money, and I think, oh, they're going to do this, of course, because our goal is to cover everybody. And then I find out that plan was called a single-payer plan, and that single-payer is not politically viable. So that was sort of what started this journey for me, because I think that, that to me, politics is supposed to be the government of the people, by the people, and for the people. And if this is what the people need, then we need to make it politically viable. So, so since then, though, I've been a student, looking, watching, learning, trying to figure out what it is that's keeping people from buying into this idea that we can give everybody health care and reduce costs and save money. And so I've evolved to the idea you'll hear about today. So I don't need to tell you guys this because you're Healthcare for All Colorado. You know that the new numbers are 49.9 million uninsured in the United States. In Colorado, our population is now 5,029,000, and we have, as of this week, the Colorado Health Survey revealed that we have 829,000 people uninsured, or 16% of our population. The other thing you may not know is that there are an additional about 630,000 people who get government insurance just from the state, Medicaid. So in addition to the 829, 629,000 get Medicaid, so 29% of our population is either uninsured or covered by the state already. This just shows you what the impact has been on Medicaid because of the recession. You'll hear a lot this coming session about how expensive Medicaid is. We need to cut Medicaid. It's costing us too much money. Well, the reason is that people are losing jobs and they're becoming impoverished, and then they qualify for Medicaid. And unfortunately, just at the time when people are going broke, the government is also going broke because they don't have any money to spend, so we don't get our state taxes in. So it's counter-cyclical. You know, we need more Medicaid when the government has less money, and that becomes a flashpoint for many people. So as you can see, from when the recession began in about 2007, we've increased our Medicaid population 40%. And this is despite the fact that if you do not have a disability and you do not have children, it doesn't matter if you make no money, you do not qualify for Medicaid in Colorado. That's planned to change in 2012 by 10,000 people only. So this is, aside from the fact that we already don't cover adults, and already this is what our Medicaid rules are like, just based on poverty alone. You know, when you look at the Colorado Health Survey, what they will tell you there is that 85% of people say they don't have insurance. Of those 630,000 don't have insurance because they can't afford it. And this is a graphic depiction of what's happened to the cost of premiums for insurance from 1999 to the present. I can tell you that the estimate is that the premiums will go up another 9.4% in 2012, which would bring this number up to $16,490 for a family policy. And as those of you who are part of the 99% know, $16,490 is a lot when you make $42,000 a year. And that is what 50% of our population makes. So I don't think that there are a lot of people out there being irresponsible. I think there are a lot of people out there who just can't afford to purchase insurance. One of the other things that Colorado Health Survey showed was that of our 869,000 uninsured in Colorado, 96.3% of them earn under 400% of the federal poverty level. And so those people will all be eligible for subsidies under national health care reform. But again, if 96% of your uninsured earn less than 400% of federal poverty level, and they give you an example, that would be about, next slide. That would mean for a family of 4, they earn under $88,200. They just don't have the money to be able to afford to buy a policy. I put these up for you because a lot of things that you're going to hear about in national health care reform and in Medicaid are related to poverty levels. I should weigh these. I'll give these to Dick Barkey so that he can put this on the Healthcare for All Colorado website. You can pull any of this down that you'd like. I do want to make it clear though that poverty is not the same, saying you're impoverished is not the same as saying that you can afford to live. So if you're not at poverty level, it doesn't necessarily mean you have enough money to live. And this is something that our Colorado Fiscal Policy Institute released sometime about a month ago. And it shows what the self-sufficiency standard is. So how much money would a family need to earn to be able to pay for food, clothing, housing, utilities, and transportation, childcare, education, and hopefully have something left at the end of the month. And so that obviously varies depending on where you live. Pueblo County, for example, the average for 2 adults with 2 children would be $46,759. But what you need to know is that's actually 209% of the federal poverty level. So our standard of poverty is lower than what it really would cost to live the kind of life we'd like people who are identified as being Americans get to live in our country. For Denver, you can see you need to be at 250% of federal poverty level to have a chance of living an ordinary life. A lot of people have employer-sponsored insurance. Last year, the number went down by 1.5 million in the United States, and the reason is that the cost for employer-sponsored insurance is going up dramatically as well. This is a graph. The top number is how much insurance costs have increased. The bottom is how much salaries have increased. And this is why you hear people say that you earn less now than you did in 2002. Your salaries have not kept pace with the cost of living. In some cases, if you have an employer who provides you with benefits, because more of their money is going to buy you benefits. This is a complex slide, and I don't want you to get overwhelmed by it, but I would like you to look at the orange number, which goes from being really big at the top to really little at the bottom, and the gray number, which goes from being really small. It didn't even start in 2006, and it's increasing as of 2011. What the orange number represents is what we used to think of, those of you who are older like me, and I'm not even that old, okay, but what we used to think of as good insurance, which is like the typical Blue Cross Blue Shield plan, where they pay 80% of anything you get, wherever you get it, and you pay 20%. And as you can see, the number of people who get that kind of insurance plan now has gone from 73% down to 1%. So most people do not have that kind of insurance plan anymore. And that's the classic plan with choice that people always talk about. We don't have plans with choice anymore in the United States. But what's concerning to me, though, is that little gray number at the very end that started in 2006 at 4% and goes up to 17% now. And those are what are called high deductible health plans. And this is an important concept for you to understand because very often this is what the conservative people in our community tend to suggest that we should do with our population. And what this means is that you pay a certain amount of premium so that if you get a catastrophic disease, you're covered. You don't lose your home and you get some coverage for that. But the day-to-day stuff you pay out of pocket. And so the number of people who have that kind of plan has gone from 4% to 17%. It's higher in younger people. But what out-of-pocket means can be really daunting. I met a gentleman in Fort Collins the other day, and he and his wife are about 60 years old. They make Colorado furniture, and they have their own business. They have a high deductible health plan. They each pay $350 a month for their high deductible health plan. Their deductible is $10,000. So they have to pay their first $10,000 out of pocket before the insurance kicks in. So his wife has glaucoma. Not that bad a thing. But the glaucoma eye drops, the cheapest he could find in Colorado was $99 at Walmart, and it took him a while to find that out. You know, it's interesting, he got them from Canada for $30. Then he found out that's illegal. So he found out there's some company in Kansas that ships in money from Canada, and then you can order it from Canada to your house. Now, I mean, I'm glad he found all that out, but isn't that a little ridiculous that he had to do that? But that's what he had to do because of high deductible health plans. And the number of people who have really high deductibles is increasing dramatically. And, you know, it depends on your income, but let's face it, if you make $45,000 a year and you've paid $16,000 for an insurance plan, having a $1,000 deductible is a lot of money. And so this is how many people have $1,000 deductibles on their health plans, people who have an employer-sponsored plan. So you can see 50% of all small firms have at least a $1,000 deductible after they purchase their insurance. So this speaks to the affordability of health care. So when you add, there's another number that people like to describe. It's called underinsurance. And what underinsurance means is that after everything is said and done, you're still having to spend 10% of your income on health care. And so that's considered underinsurance. And in Colorado, that number is estimated to be about 675,000 people according to the household survey. And so if you look at our population that's uninsured or on Medicaid or underinsured, you're at about 42% of our population. So I don't think we're doing a very good job with our current system of protecting and providing access to health care for our population. I think there are a number of things that the Affordable Care Act has done that are really quite remarkable, and I don't want to understate the importance of what President Obama was able to get through. One important thing is it prohibited rescission. I don't know, I bet a bunch of you saw Sicko and saw those companies that literally paid somebody to go through your medical record to see if you had lied about anything, so that if they found out you had breast cancer, they could drop you and not have to pay your breast cancer bills. So that's illegal now. It's prohibiting denial of coverage to children with pre-existing conditions, what's interesting is last year in the legislature, we had to pass a bill saying that if you offer coverage, you have to offer coverage to children because insurers were just going to not offer coverage to children because they didn't want to have to cover kids with pre-existing conditions. It's eliminated lifetime limits on coverage. It's requiring free preventive care, and that is great. I mean, I think it's good that you can get screened for breast cancer, colon cancer, and diabetes, but as a doctor who works in internal medicine and treats people with chronic medical disease, I can tell you that diabetes is not a cheap disease to treat. And it's really sad to find people who have this disease and can't afford the treatment. So it's great that we're screening, but we need to be sure that people can afford to take care of their chronic illnesses once we've identified them as well. And then one of the best things I think it did was it allows children 26 and under to stay on their parents' coverage, even if they don't live in their home, even if they have their own job. And that resulted in 1 million more young people having insurance last year. This year, as many of you have heard, they've implemented requiring insurers to have a medical loss ratio of 80 or 85%. Now remember, you're paying your money for an insurance product, and if they have to pay for your health care, they consider that a loss. It's a little warped. But now we're saying, look, if we give you money to pay for health care, you have to pay at least 80% of it if you're a small insurer, individual market, or 85% if you are a large insurer or a large group insurer. And this number is actually being fought over as we speak because the insurance brokers want to say that paying an insurance broker fee is a medical cost. And they don't want that to count toward that number. And so you should write to Jim Reesberg if you can and say, don't let them do this. They're working really hard to undermine the medical loss ratio at the federal level through the National Association of Insurance Commissioners. There's a prescription drug discount now for seniors. Those of you on Medicare know that at a certain point, if you spent so much on drugs, you have to pay full price. Now you can get brand name drugs at half price in that donut hole. The Center for Medicaid and Medicare Innovation is getting really active, and some of you might have seen a lot in the newspaper about their push for accountable care organizations. There's an independent payment advisory board that is looking at how can we redo payment. For the longest time, actually, most of the doctors on the board are subspecialists. And so that might account for why your primary care doctors get paid so much less than subspecialists. So they're looking at changing that to pay for value. And then a community first choice program. And this is a program that's pushing to get people out of nursing homes and into the community because it's where they want to live. And it's cheaper, which is nice. In 2012 and 2013, they're piloting those accountable care organizations. They're working on streamlining administrative functions. They're looking at different ways to pay for hospital care, something called bundled payments. And this is all another lecture if you're ever really interested in it. And they're going to increase the Medicaid payment to primary care providers for at least 2 years to try and help more people on Medicaid get a primary care provider. And then 2014 is the big year when everything really is set to happen. That's when it's going to be illegal to prohibit offering an insurance policy to anyone based on a pre-existing condition or gender. And that is when the individual mandate comes into being. And what the individual mandate is, you know, when we talk single-payer health care, those of you who talk single-payer health care, you're talking about everybody contributing, right? Well, this is the same thing, but in private insurance. The difference is in single-payer health care, you contribute according to your ability to pay. In this, it's a flat fee. So then you still run into the trouble with the price being too much for a lot of people. But anyway, so the individual mandate is to say we need everybody in the pool if we're going to cover everybody. And as you know, the Supreme Court has agreed to hear that case in next spring, and we should have an answer by next June or July of whether or not this is constitutional. Starting in 2014 as well, there will no longer be annual limits on insurance coverage. Medicaid is to be expanded to 133% of federal poverty level, so all those adults in Colorado right now who have no access to Medicaid, starting in 2014 will. Now, I didn't realize this is also part of the Supreme Court challenge. The states are saying, is it legal for the federal government to put a mandate on us without giving us money to pay for it? So that's in there as well. And then the premium tax subsidies for people at 133 to 400% of federal poverty level will start in 2014. In addition, there are going to be some cost-sharing subsidies to help people with out-of-pocket costs if you're at less than 400% of FPL. Some small business tax credits, and of course, the health insurance exchange. As you know, Colorado was one of maybe 9 states last year that passed an exchange. I heard we were one of only 2 that did it with a bipartisan legislature. Everyone else who did it because they had Dems on all sides. And we are in the process of trying to implement that. We had a little bit of partisanship in September because we were supposed to submit our grant for continuing the exchange. And the chair and vice chair from the 2 parties, and we couldn't get approval. And so now they have to resubmit the grant to the whole Benefit Exchange Implementation Oversight Committee. And I am a member of that committee. And I think we're meeting December 6th, hopefully, to talk about what happens with that. So hopefully we'll be able to move that forward. I know the governor is behind it. The 5 big associations for commerce in the Denver metro area are behind it, so hopefully we'll be able to move this forward. And in 2015, a lot more effort on paying physicians based on value and not volume. An analysis was done by Dr. Gruber, who's a big health economist known nationwide, but what would be the outcome in Colorado at the end of, or who are the people in Colorado and who will benefit from the exchange? And as you can see, again, most of the people are at under 400% of federal poverty level. This is old data. Obviously, we have new data this week that says that 400% number is only 3%, but most people will benefit from the exchange. I did mention the exchange. I won't go into this in too much detail, except to mention there are 12 people on the exchange, and then there is an oversight committee, so it's a little bit cumbersome. So the oversight committee has to approve any contracts that the exchange goes into so that we don't encumber the government to anything. And so that's the committee that I'm on. The exchange is the committee that many of you know Nathan Wilkes, and he is on the board of the exchange. And so what they're really going to try and do is develop an individual market for the uninsured and a small business health market as well. And the idea really is to have something where you can go in, put in all your numbers and find out, do you qualify for Medicaid? Do you qualify for a subsidy? And what are the insurance products that you could buy? And ideally a program that would say these would be the best ones for you based on your age and health status. At the end of this in 2016, it's estimated that the number of people on Medicaid would go up another 160,000, and that the uninsured would decline from 860,000 to 400,000. So it's expected that we will still have about 400,000 people uninsured at the end of full implementation of the Patient Protection and Affordable Care Act. And of those 400,000, approximately 39% are uninsured because they're not documented. Because as many of you know, the undocumented are not eligible to benefit from federal health care reform, and that's about 120,000 people in Colorado. 160,000, sorry. 160,000 undocumented. 120,000 will, even with all the subsidies and everything, it will still cost them too much to buy insurance, and they'll be given the buy, saying, okay, you don't have to buy insurance. Now, they're still uninsured, but they're not going to get the tax penalty. And then about 88,000 are probably libertarian, and they're saying, I'm just going to pay that penalty because it's cheaper and you can't make me buy insurance. So, this is from, I used to title this talk, What's the Elephant in the Room, and I forgot to go through and get rid of my elephant. But I want to, you know, to me this part of it is about explaining to you why it is I'm so outraged that people say this is not politically viable to redo our system, and why I think it's just such a black and white thing, and why I get annoyed when people say, you know, oh, this will never happen. And in fact, I said my goal in the legislature this year is to get legislators from saying this will never happen to saying, wow, Irene, this should happen, how could we make it happen? And that's my only goal, is to have people look at possibility, not inevitableness, because I think ultimately, of the people, by the people, for the people, we can do this. So the first reason I'm so outraged is that, as many of you know, and you hear this all the time, the United States spends more than any other developed country on health care in the world. And so the overall numbers you see there, the red bar, what the red bar represents is actually, there's this hidden cost the United States pays for health care. What that is that if you get your health insurance through your employer, you don't pay taxes on it, and that ends up being spread across the population that each of us gives up $1,000 in tax revenue to allow people who get insurance through their employer to get insurance. So if you look at that red bar, then it means that the United States spends approximately $4,500 per person just purely from the government on health care. And if you look at all those other countries, there are only 2 that spend more than that total. And so we have enough money right now in our health care system, if we redesign how we do this, to give us a Canadian system, a German system, a French system, a Denmark system, a Swedish system, with just dealing with the federal government money that we have right now. That's without asking people to pitch in more than they do in taxes. And even though we pay a lot more, it's not because we do a lot more. This is how many times we visit the doctor versus the other country's average. It's half as much almost. And this is how long we stay in the hospital versus the other countries. It's 30% less. This is how, and then this is a mortality data on our infants who are born and how often they die compared to all these other countries, and it's more. So we're not paying more because we have a better healthcare system. Now, as my friend Vince Markovic will tell you, if you are wealthy and well-connected, we have the best healthcare system in the world. If you are the prince of Saudi Arabia and you need to get fixed, you come to the United States, you'll get the best treatment money can buy. But if you're the average Joe on the street, you're going to get these numbers. The other thing that outrages me is that health insurance coverage is not the same as access to health care. And this shows you where our health care providers are located around the state of Colorado. And even though I represent the city and county of Denver, I care about our whole state. And we can give people in southeastern and northwestern Colorado all the insurance we want, and they're not going to be able to get to healthcare providers in an easy way unless we do something to fundamentally change our distribution of healthcare resources. And without a unified system of care, we're not going to be able to do that. So why are the costs so outrageous? Because this is what we keep hearing about. The costs are so outrageous. Well, the costs are outrageous because we have a great market in healthcare. The way our market works is that the more you do, the more you get paid. So the market is working, right? In fact, I like to tease that the most expensive piece of medical equipment is a physician's pen, or maybe it's a computer with the physician's ability to sign on it now because we do electronic order entry. But every time I click that order or write that prescription, I am causing healthcare costs. Now, if I keep you completely healthy and I don't ever need to see you, I lose money and there are no healthcare costs. Oh my gosh, that's awful. You know, a lot of people have said that Obamacare is like Romney care, which Romney is not denying, but this is what's happening in Massachusetts. Massachusetts costs have increased 42% for healthcare, and it's estimated by 2020 that it's going to increase 8% faster than their gross domestic product. And this is why everyone's so afraid, because it is true that if we do nothing, if we just keep going the way we are now, our costs will be unsustainable in healthcare. Now, this is the part that also makes me angry. I refer you to the article by Atul Gawande in the New Yorker called The Cost Conundrum. This is called the Dartmouth study, and this shows you Medicare spending across the United States. And the darker it is, the more Medicare money is spent. So you can see down there at the very tip of Texas, deep in the heart of Texas, no, down in the tip of Texas, McAllen, Texas. And McAllen, Texas has one of the highest Medicare spending rates in the country. They have the largest density of cardiothoracic surgeons, and guess what? They get more cardiac bypass surgery than anywhere in the country. But you know what? Grand Junction, Colorado has the best health outcomes in the country. And you'll notice they're pale yellow. They're not dark red. So this is where I like to tell you that more health care does not mean more health. It really does not. And we need to sort of step back and say, you know, is healthcare dangerous? And I sort of love the patient safety stuff that's coming up now because I think there's more recognition that more is not better. This is to show you that right now we don't pay people based on how good they are. This gives you an idea of how much Medicare spending there is in three big medical centers, UCLA, Mass General, and the Mayo Clinic, and what their quality scores are. So you can see Mayo has the best quality scores of the three centers, but they have one of the lowest costs. So more money does not mean better quality. Interesting. This is a classic PhD slide. What I like to say is that if you take this out now with federal health care reform, that yellow line is going to continue to very slowly increase. What that blue line is going to do what the CO2 emissions did in Inconvenient Truth. You're going to need to get on an escalator to the point where it's going, because now we need to know what percentage of federal poverty level are you at? How much of your income do you have to spend on health care? Do you need a subsidy? You know, and what kind of plan do you need, and how will we define essential health benefits, and what 60, 80, 90, 100% of that, blah, 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 blah. So you can see how this is potentially going to escalate. Oh, this is last thing I like to say that in our current healthcare system, we'll spend $1.50 to be sure we don't give you $1 more of healthcare than you deserve. But the bottom line is that when you've had that stroke and you've become disabled and you've lost your job and you've lost your home, we will cover you with Medicaid. Is that the kind of government we want to be? You know, insurance companies are just inefficient and wasteful. This is how much we spend on health insurance administration per capita. This is back in 2007 compared to all those other industrialized countries in the world as well. This is the financial burden on physicians for getting payment from insurers. And you can see how much millions is spent every year in the United States on this. There was an article in Health Affairs 2 summers ago that said that for one doctor to be an independent practice and take insurance, it would cost $65,000 to $80,000 a year for him to do all of the billing that he needed to do and make all the contracts, et cetera, et cetera.
Are those percentages or dollars?
This on this slide is millions of dollars, and this is national. You know, one of the big winners in national healthcare reform were biopharmaceutical companies. They get a 12-year patent on biopharmaceuticals, and there was an article maybe 3 weeks ago in the New England Journal of Medicine. You know, when a drug company had, I always wondered why insulin was so expensive, because we've had insulin forever. But when a drug company has a patent, when another company wants to make the drug, they have to notify the drug company that they're going to create a generic. And then right now what's happening is some drug companies are paying that company not to make the generic and buying themselves 5 more years of having an exclusive market on that drug. I forget what the name is for that. Did you remember that? It was from New England Journal 2 years ago. But anyway, they're looking at trying to make that illegal now. And then the other thing is they put a patent not only on the active ingredient, but on what it's mixed with. So then so if they change what it's mixed with, that patent expires at a different day. I mean, it's just such a game. It's really quite annoying. So if we're not going to reform the U.S. healthcare system, I would suggest that everybody invest in pharma and pharmaceutical companies. You're going to need that money later. And here's the worst part about it. This is the drug prices for the 30 most commonly prescribed drugs in the United States versus all those other countries that have healthcare less than us. Now, if we're doing all the research, if we're making all the great investments in it, why is it we're paying more for these drugs than all these other countries? It doesn't make sense to me. And frankly, it makes me angry. So this is, many of you remember Barry Keane, who was head of HCAC for a while, and he worked with Representative Kefales last year to pass something called an all-payer claims database. There are some other states that have this. When you get the information on exactly what people are paying for things, you're amazed at how different it is. Like, so if somebody came to see my husband, say, at his pulmonary clinic in Lakewood, depending on their insurer, how much was actually paid to him would vary. So this is what I'm going to show you. So for example, this is in the United States, the variation in price for MRIs. It can be anywhere from, the average of $1,000, it can be as high as $1,600 to get an MRI. And then you can see what they pay for that same service in other countries. This is the difference between private, Medicare, and Medicaid payment for professional procedures. And this is why people who are on Medicaid and Medicare can't find doctors willing to treat them. They get paid less when they treat you, right? How does the market work? The more you make, the more you want to do it. So if I get paid $100 to see somebody with private insurance and $50 to see somebody with Medicaid, who do I want to see? You know, that's a market. And then, so office visit differences in prices, MRI scans, colonoscopies. You can see there, an office visit can be as low as $45, as high as $330. This is an example from the all-payer claims database in New Hampshire. So this shows what one insurer pays for a colonoscopy. Depending on who they've negotiated their contract with and who they're representing, it's anywhere from $1,300 to $4,600. And if you compare that across insurers, you can see that some insurers can get that same product for as low as $1,195, and $4,600 looks like it's the maximum there on that plan. Mammograms, $129 to $881. Mammogram, same place. MRI, same thing. Does this make any sense to any of you? It sure doesn't to me. And you know what's interesting is last year, one of the bills I really got pummeled on by doctors, so if any of you are doctors, I apologize, was that they brought this bill to try and decrease malpractice costs. And the thought was that if somebody is injured and their hospital bill has to be paid, right now the settlement is based on what the hospital bills you, not on what the hospital gets paid. So you know how you get those hospital bills and it says the bill is $50,000 but your insurer is paying $6,000? Well, what they wanted to say was, well, then for malpractice we only have to pay $6,000. And I said, you know, that doesn't really seem right, because if the price isn't $6,000, the insurance company, or isn't $50,000, they shouldn't be billing $50,000. So I said, so rather than trying to get us to say we're going to pay patients less, why don't you get the hospital to say they're going to pay you what it really costs? But they didn't like that idea. I think they just didn't know how they could do that, to tell you the truth. And they thought it was easier to try and do this and push it off onto malpractice. You know, there is no competition in health insurance. Most insurance markets are concentrated. And this shows you the market share of the top 3 private insurers in different states. And you could see, for example, Wisconsin, the top 3 insurers have over 80% of the market. So it makes it really hard to compete when when as a provider you only have one insurer that you have to deal with. You know, I always fluctuate, should I leave health industry profits in there or not, but I guess fundamentally, at a very fundamental level, I really don't think that people should profit by other people's illness. I just don't, and I know that makes me a bleeding heart liberal or a Christian. I like to think it makes me a moral American personally, but that's just my own personal opinion. And this also appalled me last year during the recession. People are going broke, people are losing their jobs. You know, even though less people have insurance, the insurers are making more money because the people who have insurance are healthy and don't need access to the health care that that insurance provides you. And these numbers are the profits in the first half of 2011 for 4 of the largest insurers in the United States. And what I wanted to tell you also was that profits does not include the salaries that their CEOs make, because that's a business expense. Profit is what's left over afterward to go to their shareholders. So as an example, the CEO of Cigna in 2008 made $25.8 million. The CEO of Aetna made $18.2 million. And I really feel sorry for the CEO of United because he only made $8.9 million. This is what things cost in the United States versus other countries. So this is where I like to say that if you need your hip replaced and you don't have insurance, take a vacation to Switzerland. Because you can get a hip replacement in Switzerland for $6,683. And in the U.S., the average price is $35,000. And, you know, what's interesting is that I read this article in AMA News maybe a year or two ago. There's an insurer in Wisconsin, an employer, and they self-insure, and they will pay for you to fly to India with a family member to get your elective surgery done. Save some money. And actually last year, some poor guy, he didn't know who I was, came to talk to me about what we could do to try and make the laws easier for doctors who practice medical tourism, and I said, you don't want to talk to me. He insisted, and at the end I kind of gave him a lecture, and my aide was like, he really didn't need to talk to you, did he? Anyway, you know, I think insurance is the wrong model. The idea behind insurance when it was created way back in the 1930s was that a very few people would need it for very few extraordinary things that happen. And back then, people only lived to be maybe 60 years old, which is maybe no accident as to why Medicare started at 65, right? They weren't going to be that But now, our life expectancy is 78 years of age. And that's certainly part of why Medicare is going broke, right? It starts at 65, we're living to 78. And when are most of us getting sick? When we're older. And so everyone gets medical care. I mean, we get it ideally, you get preconception counseling. Ideally, you're given birth control, but that's a different story. But then, you know, preconception counseling, care around the birth of your child, care as your child grows up, immunizations, unless you want, you know, unless you're afraid to get mental retardation, but that's a different story also, et cetera, et cetera, et cetera. And most of the costs right now, actually 85%, go to caring for people with chronic disease. So it isn't the thing that's not going to happen very often. It happens to you if you live long enough, basically. And so I wanted to show you that, you know, an interesting figure is to think of it this way, that 50% of our population only spend 3.1% of our healthcare dollars. 50% of us are blessed enough to be healthy and not need a lot of healthcare. Just need a little bit of prevention, you know, a little bit of routine health maintenance. But it's the other people who need more money, and really the unfortunate top 5 or 6% who need the bulk of the money. So what did I come up with as my Colorado Healthcare Cooperative? Many of you know that a cooperative basically is a non-governmental, and I had to pull government out of it because nobody likes that word, it's like a dirty word. Non-profit, member-owned and operated corporation. In this case, every resident of Colorado would pay into it and be an owner member. And it would operate basically for the benefit of Coloradans. The goal is to provide quality health care for everybody while saving us money. So it would be truly universal. There would not be 400,000 people uninsured at the end. It would be affordable, and by this I mean that everybody pays in, but you pay in according to your ability to pay. You know, I worked for Denver Health and Hospitals. My insurance plan 2 years ago cost between the city and I $24,000 a year. The city paid 12 of that, and I paid 12 because I was a half-time employee. But you know, that clerk who works in my clinic, who makes maybe $18,000 a year, she also would have had to pay that amount of money for health insurance. And I just don't think that's fair. It would be accountable and transparent. We would have a publicly elected board of directors with campaign finance reform. And they would be accountable for health spending and outcomes. We would have to engage our members on what our design, evaluation, and benefits would be. You know, it may be true that we can't afford to provide everything to everybody, but why don't we as a people decide on where we're comfortable drawing that line as a citizen of this country for the common good? And then it would be equitable and consistent. It wouldn't matter if you were the king of Saudi Arabia or an everyday citizen in Colorado. You would get the same access guaranteed by your healthcare dollar. We need it to be comprehensive. It's very important that we spend money on prevention and on early intervention because it's cheaper than taking care of diseases when they get really sick. This reminds me of my patient who I said was part of why I became so active in healthcare. I had a woman who came to see me at age 45. She had diabetes. She worked as a secretary, didn't get health benefits. She could not afford to take care of her diabetes. She frequently would come in and say, well, I have this much money, which of these medicines should I buy? About 5 years later, she lost her kidneys from diabetes, which is the most common reason to end up on dialysis right now, and she got Medicare. So now we're paying for her health care. I couldn't help her get her high blood pressure medicine, I couldn't help her get her insulin, I couldn't help her get her glucometer when she was 45 and working. Her kidneys are failed, she's disabled, and I'm paying for her to be on dialysis. And she actually died by 60 of coronary artery disease. And by comprehensive, I don't mean that we need state-of-the-art sky ridges everywhere in Colorado, but you know, we know that if we can get you to the hospital within 4 hours of having chest pain, you have a better outcome. So we need to be sure that, unless you're climbing a 14 or you're on your own, but if you're anywhere in Colorado, that you can get somewhere where you can get to an emergency place that can stabilize you and get you to a center of excellence within 4 hours. We would like to be able to choose our providers. You know, to be quite honest, I think you can always choose your primary care provider. I think it will be harder to choose your specialist because of the way medicine is going to be redesigned. But if you have a really good primary care provider, hopefully they've done the work of picking what specialists they choose to work with. But I think we need our healthcare system to be designed around the patient, and if anybody paid is going to be in there, it's just their provider. It's not the insurer, it's not the employer. We need our healthcare systems to be integrated. You know, Denver Health provides care for the largest amount of people on Medicaid and uninsured, and operates in the black because they're integrated. They're all working toward the same goal, which is keeping the person healthy.